Welcome to the Pharmacists Transforming Care in Patient-Centered Medical Home and ACO conference call. My name is Richard, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Ms. Gloria Piso. Ms. Piso, you may begin.
Good afternoon, and welcome to a seminar. Our webinar is being presented by the Lake Superior Quality Innovation Network, which is comprised of 3 organizations: MPRO from the state of Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, supporting the Centers for Medicare and Medicaid Services Priorities for Healthcare Quality Improvement. I would like to introduce you today's speaker, Dr. Hae Mi Choe. Dr. Hae Mi Choe received her baccalaureate degree in biochemistry and cell biology from the University of California, San Diego, completed her Doctor of Pharmacy from the University of California, San Francisco. She completed her pharmacy practice residency at Kaiser Permanente, and after her residency, she moved overseas and developed and implemented an anticoagulation service and asthma service for the first time in South Korea. After 5 years, Dr. Choe joined us in the United States at the University of Michigan Health System to develop ambulatory clinical services. She was the first pharmacist evaluated and endorsed by the Credentialing Committee at the University of Michigan Health Service and was granted special privileges in patient care. Dr. Choe created a group practice model at the University of Michigan as part of the patient-centered medical home and has spread it across 14 health centers. She's also developed a new reimbursement process for clinical pharmacy services. Dr. Choe has been recognized and awarded nearly year after year for state and national organizations for her innovative programs, her best practices, and her excellence in teaching and experiential education. In 2011, Dr. Choe and her colleagues received state and national recognition from the Michigan Pharmacy Association Innovative Pharmacy Practice Award and the ASHP Best Practice Award for their group practice model in the patient-centered medical home. And most recently, she's received the 2014 American Pharmacists Association Pinnacle Award for Individual Career Achievements. At this time, it's my privilege to introduce you and turn it over to Dr. Hae Mi Choe.
Gloria, good afternoon, everyone. Thank you for joining us today for the webinar. I wanted to just briefly review the learning objectives for our webinar, and then I'll proceed with the presentation. We're going to define the patient-settled medical home in terms of the characteristics and components of the medical home, and identify the potential role for pharmacists and possible barriers to including pharmacists on the patient care home team. Outline strategies for demonstrating the value of pharmacist involvement in patient-centered medical home, and also describe the emerging opportunity for pharmacists in the accountable care organization. So I know most of you on the call probably already know the concept of patient-centered medical home, but for those that may not be as familiar, I thought I would kind of give the definition as I interpret what the patient-centered medical home means to me. The patient-centered medical home really embodies a new care delivery model that replaces episodic care with coordinated care. So rather than waiting for patients to seek medical help when there's urgency or there's something wrong with the patient, but really replacing that with coordinated and more proactive care. Patients have a team that takes a collective responsibility for meeting patients' health care needs. So meaning that it's no longer just physicians who's taking care of the patients and looking and managing patients, but we have a team that takes the accountability and responsibility for taking care of the patient's chronic needs. And it really centers around ongoing relationship with primary care providers, and where primary care providers is really providing the foundation for building that patient care team. Some of the joint principles for patient-centered medical home, I know there's different domains out there depending on which entity that you look at in terms of principles for patient-centered medical home, but I think they all have common theme that it is centered around patient team-based care. There's a robust care management component to the patient-centered medical home, test and referral tracking, patient management support, really empowering the patient to take more ownership of managing their health care rather than those of us in healthcare to tell the patients what to do and how to do. Measure and improve performance, being cognitive of what our metrics are and being able to track that and see how we're doing in terms of improving in our performance. Patient tracking registry functions, and an advanced electronic communication, as well as enhancing access and communication with the patient. So at University of Michigan Health System, we have patient-centered medical home team members that comprise of physicians, pharmacists, nurses, social workers, dietitians, medical assistants, panel managers, and office assistants. So truly, all disciplines is represented in our patient-centered medical home team, and we work very cohesively together to improve the care of the patients with chronic conditions. I wanted to focus today on what the role the pharmacists contribute in the patient-centered medical home, while all the disciplines contribute in a meaningful way to improve the care of the patients. I thought I would spend the rest of the afternoon focusing on the pharmacist's contribution to the model. So at University of Michigan, we have 10 embedded pharmacists in all of our primary care clinics. Even though I have 10 pharmacists in the clinics, really, if you're looking at the clinical FTE, I have 4.9 clinical FTE that spans the whole health system. And we cover 9 internal medicine clinics and 6 family medicine sites. Pharmacist time at these PCME sites can vary depending on how big or how small the health centers are. Some of our health centers, I have pharmacists there half day a week, and some of our larger health centers, I have pharmacists there 3 days a week. In terms of what we do at the practices, we have 2 service lines. So one is disease management services, focusing on diabetes, hypertension, and hyperlipidemia. And the second service line we offer is the comprehensive medication review. So basically, why those 3 conditions? We recognize that diabetes, hypertension are really the bread and butter of primary care and makes up a bulk of the patients that we see and manage for chronic conditions. And also a lot of the quality metrics that's out there, whether through the private insurances or through ACO, many of the quality metrics is surrounding these disease states. And we also wanted to be mindful of that while pharmacists can provide a wide array of disease management services, we wanted to make sure we dig a hole deep enough so that we could really demonstrate the impact that we have in patient care rather than spreading our resources across multiple disease states. And comprehensive medication review are really the patients that come into clinic and they might be taking 15, 20 medications, and physicians are already running behind, and patients have all these questions as to what they're taking, why they're taking. And so these are the type of patients or situations where pharmacists could step in and really help physicians to be able to take ownership of that explanation or counseling the patients. And we also help physicians by reviewing the meds, focusing on, is the patient on the best, most efficacious medications? Are they on the safest medications? And also, are they on the most cost-affordable medications? And so with those 3 things in mind, we look through the medication, look for opportunities to improve therapeutic regimen, and then we communicate closely with the physicians to make any changes that's needed. And the reason I think this allows us to do this seamlessly is because we work in the clinic with the providers side by side, so we have easy access to our physicians. We have full access to medical records so that we're able to document in real time in the medical records in terms of what services we're providing. And at the same token, we could actually look at the things that have happened to the patient prior to our visit so that we make sure that our services are in sync with the medical providers and make sure we're providing continuity of care as well as coordinated care. Pharmacists have collaborative practice agreement with our physicians, which allows the pharmacist to do certain functions that the physicians delegate. And that includes evaluating and optimizing treatment regimen. We provide medication management to achieve treatment goals. So for patients not achieving A1C goal or blood pressure goal, a pharmacist is able to intensify treatment to make sure that we meet the treatment goals. Assess and address barriers to medication adherence. So this is another area the pharmacists focus our efforts on. As you know, there's medications prescribed, maybe about 30 to 50% of the patients actually don't take the medication as prescribed. So if you're thinking about the medication that's either unused or used incorrectly, that poses a lot of issues in overall care of the patient. So we're addressing the barriers to taking the medication as well as what we can do to help streamline that process. We also focus on providing education not only on medications, but also on chronic conditions. So helping them understand that why they take drugs as for what condition and why that's important for them to continue to take the medication, even though, their glucose might be under better control or their blood pressure might be better under control. So we spend a lot of our time explaining and counseling patients on their chronic conditions as well as medications. We performed a limited physical assessment for the patient. We could order labs and facilitate ordering the medical equipment. Also, if patients, let's say, has diabetes and has not been to an ophthalmology, we are able to facilitate that referral on patients' behalf. We also spend a lot of our efforts in helping patients set self-management goals and utilizing motivational and intervening strategies. We find that empowering the patient not only with the knowledge that they need, but helping and coaching them to take more ownership of their health care has been a very important part of the success that we were able to see in patients. I want to go back to the service line that we provide and kind of do a little deeper dive into the services in terms of how we deliver the care. So as I mentioned earlier, for disease management services, we focus primarily on diabetes, hypertension, and dyslipidemia. We also proactively identify patients using our disease registries or looking through physicians' clinic schedule. The reason we do that is we find that in a busy clinic day, it's oftentimes it's difficult for physicians to remember to refer the patient to the pharmacist. Given that they're taking care of head to toe and they're already facilitating many referrals, even though they recognize the value that pharmacists bring to the table, it may not trigger their memory to refer the patient to the pharmacist. So rather than just waiting for the referrals to come our way, we actually proactively man the registry and identify patients that we think would benefit, and then we coordinate with physicians to ensure that patient would indeed be someone that we should be reaching out to. So we do a lot of proactive outreach to the patients. Patients are scheduled for initial half-an-hour appointment, face-to-face, and that's something that we prefer to do. But however, if the patient is unable to come in person, we could also meet that need by conducting it through the phone. Patients are scheduled for anywhere from 15 to 30 minutes follow-up to improve disease control or medication management. We really foster more of that frequent touches rather than long visits with the patients. We find that chunking our appointments to more frequent appointments with the patient really helps to engage the patients and have that connection and build that relationship with patients. So we really looked at the way we conduct our visits, and we've streamlined our processes so that we're more efficient with our clinic visits, and then we're touching patients more frequently. The comprehensive medication review services, our initial appointment for the CMR services is just focusing on patients' medication concerns, confirming that patient actually has an indication for the medication. assessing patients' understanding of their disease state and their treatment plan, and identifying barriers to treatment, including drug costs. And this is something that really hits home for our seniors, especially those who have Medicare. They're vulnerable to falling into donut holes at some period in the calendar year. And when that happens, oftentimes the patient liability in terms of drug costs increase. It's not double, triple the normal copays. So that puts a huge burden on Medicare patients who have a fixed income. And so we really work with patients to proactively anticipate it and help patients manage those situations rather than waiting for that time to hit. In 2 weeks, we schedule a follow-up with our patients, and during that time is when we really discuss the new treatment plan to improve efficacy, safety, and look for opportunities to lower drug costs. And what we do in between those 2 weeks is to discuss any issues that we might have discovered with the provider, and we might have some further dialogue, what would be the best go-forward plan for the patient. And doing the follow-up allows us to implement that plan and also to do any additional counseling and reinforcement. Both initial and follow-up appointments can be done over the phone or at the clinic, and if you combine those two appointments, it leads to anywhere from 75 to 90 minutes of CMR experience. So all those efforts led to, we looked at our glycemic control in patients and stratified it based on their baseline A1C. So patients with A1C greater than 7, A1C greater than 8, A1C greater than 9. And in each category, the patients, we reached a statistical significant difference in decrease in A1C control in all three cohort of patients. I also want to do a snapshot view of the therapeutic activities by pharmacists, and in year 3, we've actually made over 2,674 interventions. And if you look at our intervention split, it's about roughly 50% of our therapeutic interventions were really dosage intensification, so increasing the dose because patients not meeting their treatment goals. And the other half is split between adding new meds or stopping meds. We might have decreased the dose or stopped med because safety reasons. Either patient has contraindications or they might have adverse events, or we might have done it for cost reasons. So there's different reasons why we have made these types of medication adjustments to improve their overall therapy. We've also looked at some of the process measures for diabetes. So on the bottom, we tracked all the QI metrics that we follow for patients with diabetes. And yellow bar indicates patients that are not managed by pharmacists, and the blue bar represents patients that are co-managed by pharmacists and with the primary care providers. In every one of those measures, the group that had pharmacists involved in their care had a higher goal attainment in terms of reaching some of these quality metrics. And if you kind of spin the same data in a little different way and looking at whether we actually met the threshold, and when we meet the threshold, then we get performance-based payment for meeting these measures. And so the group that did not have a pharmacist involvement met the goal 3 out of 7, thereby being paid on those 3 measures. But the group that the pharmacist engaged with actually met 6 out of 7 goals. So if we were to translate that data to a larger population, that would have been the impact that we would have had in terms of getting paid on the performance measures. So while all this data is pointing to improving outcome for patients, what's really important is to make sure that we have this trusting relationship with the physicians, because none of this is possible unless the physicians trust the pharmacist to act on their behalf and work with the patient. So I've done a survey with our medical directors to see how satisfied are they with pharmacists being embedded in their clinic. And some of the questions that I've asked them was, did the clinical pharmacist positively impact the health status of your patients? I've asked the impact of collaborative practice agreement, whether they find that to be of value. I asked about whether the pharmacists provide useful communication in regards to the health status of their patient. And also wanted to see what their thoughts are about, are the pharmacists making appropriate clinical decisions for their patients, and overall what their satisfaction is with pharmacists being in their clinics. And as you can see, 4.8 was our average out of 5 in terms of physicians. And I do site visits, so all of those 15 health centers at the once a year, and I actually go and meet with the medical director and health center managers to get that direct feedback to see, what are we doing well, what do we need to do better. And it's so rewarding every year when I meet with them to get such a positive and warm feedback and how value added the pharmacists are. And now they have become kind of part of their core team. And at University of Michigan now, when a new building goes up for health centers, I actually get notified 2 years in advance when they're actually having to start the building, because they want to make sure that they'll have a pharmacist in the team when the building is actually in operation. So it's now become a part of our norm, not something that's extra, or it's not something that's a luxury, but it's an expectation and a necessity as part of our care team. What did the PCNH practice model provide us with? It really gave us the building blocks we needed for future innovations. When the specialty physicians heard about what pharmacists are doing in the patient-centered medical home, they started asking, well, we want pharmacists in our clinic. And so we started expanding the model into specialty clinics. And I now have pharmacists in cardiology, anti-coag psychiatry, CKD clinic, and we're continuously building more clinics where we're embedding the pharmacists into their clinics. Also, we've really focused on building a true medical neighborhood by collaborating with patient-centered medical home and also community pharmacies. We recognize that we have so much bandwidth within our academic institution to care for our growing population, and we thought if we could foster collaboration with those practitioners in the community who are already touching our patients, who's already engaging with our patients, and if we could just kind of break through our siloness and come together, I think we could definitely be able to provide much more comprehensive and coordinated care versus fragmented care that we live today. So we're fostering that relationship, and having a solid medical home model allowed us to build this partnership with community pharmacies, and we're going through a pilot project right now. We've also created a telehealth partnership with home care services, leveraging the technology to be able to Skype in the patients with the pharmacist, because many of these patients who go through home care services are homebound. So as much as we would like them to come in to see the pharmacist, transportation, social issues makes it very difficult for these patients that come and receive their care. So we're able to, using video technology, able to bring the patient to the forefront of the pharmacist's care. And so we have a pilot study that's unfolding as we speak. We've implemented an employer-based comprehensive med review program 2 years ago. So these are our own employees and retirees that we're offering the comprehensive med review with. And we've been able to touch many of our own employees and retirees that have led to positive impact. And we're going through some analysis right now to look at some of those outcomes. Also, working with payers to improve HEDIS and STAR measures has been something that the payers have been very interested in as we start to work. And it's really having the pharmacists embedded in the clinics and working together with physicians is addressing a lot of these STAR measures or HEDIS measures is organically grown because it's kind of embedded in our practice model. So the payers have been very interested in partnering with us to explore that opportunity. So I'm going to take a little bit of a turn and talk a little bit about what we're doing in the accountable care organization space. So we're applying the principles of patient-centered medical home and have really had specialty engagement in our processes. And we've also added the element of inpatient care and transitions of care into the fold, because under the ACO umbrella, we're responsible for the whole spectrum of the patient care, not just the primary care or the ambulatory side. And some of the ACO goals for us is to avoid unnecessary duplication of services and medical error by linking provider reimbursement to quality metrics and reducing the total cost of care for an assigned population. And we know that when ACO succeeds in saving healthcare dollars, and CMS shares the savings, and we're participating in the Medicare Shared Savings Program. Some of our target outcomes is to align our patient performance indicators with an associated financial benefits, aligning avoidance of penalties and financial impact, especially when it comes to readmission, cost savings to employers, as well as new revenue from direct billing opportunities. So we're actually participating in a national demonstration project where pharmacists are billing for our services through care management role, and we have third-party payers that pays directly fee-for-service for those services. The University of Michigan has formed a larger ACO network called Physician Organization of Michigan, and our ACO partners are kind of spread geographically across our state. We have 11 other physician organizations that are currently part of our Medicare Shared Savings Program. So they're part of our network, and we collaborate together to improve the care of our patients across our health systems. Last year, the POM ACO board has officially approved my role for the ACO, where I was tasked to replicate University of Michigan Health System patient-centered medical home program across our ACO network. So my promise to the ACO board was that I will be able to focus on 4 physician organizations to kick off the year with, and really helping them develop the infrastructure and embed pharmacists in their primary care clinics. My ask of them was to invest in hiring a pharmacist to provide services across 2 to 3 practice sites so that they could learn within their organization how to develop and facilitate these types of services. And it was an interesting experience for me, and a very eye-opening experience. I think I've experienced what it's like to build clinical programs in my own backyard. I've done that for the past 20 years, but I've never really built programs that's in somebody else's backyard. And that makes it very challenging, especially if the other backyard looks very different than yours. So I'm very used to more of the integrated health system look versus a lot of the physician organizations that I've been working with under the ACO model actually don't have an integrated system. It's made up of hundreds of individual practitioners. So how do I put my arms around an organization where they're structured very differently and they have different, even EMR access is very different. Their leadership structure is very different. So it created a new way of thinking, and how do we provide support for those physician practices? And maybe you can't embed a pharmacist in those one physician offices. So then how do we go about strategically providing support for those small practices is where we're at right now, trying to create those solutions for those smaller practices. But our focus area still is the same, in that we're focusing on a comprehensive medication review and focusing on core disease state services. So my kind of pitch to the ACO was that, they could all plant their trees separately, and no doubt they could build their own pharmacy programs. However, if we could do it together and really bundle our resources, we could actually create a forest together. And what that means for us as an ACO is then we can now create a standard of practice, really the best standard of practice, and then we have the ability to scale it and reproduce those results and be able to collect data in a meaningful way so that we can reflect on our journey to see how we can continuously improve our process. So my involvement with ACO has really broadened our look in terms of how we go about population management, especially when it involves pharmacists. So creating a new opportunity for future pharmacists. Pharmacists are being recognized as an integral member of the new care delivery model. The advisory board company was probably one of the most reputable healthcare consulting firm, and they've actually produced a white paper this year in February in response to their customers requesting about embedding or integrating integrating pharmacists into their primary care. And University of Michigan was profiled as one of the best practices within the white paper, and they've also listed 4 other great programs that are doing similar type of thing, but in a different setting. So I would encourage those of you in the audience who's interested in this type of work to seek for that white paper and read about what others are doing in different parts of the country. We also need to develop a sustainable financial model for pharmacists. And notice I stated financial model, not a reimbursement model, as our healthcare is moving away from volume to value, and as we start to talk more about performance-based payment and bundle payment rather than fee-for-service, I think it's really important for us to kind of put our arms around what that model looks like, and not so much on, are the pharmacists bringing the revenue to make their costs budget neutral. The impact on patient care and healthcare costs is going to be really important to continue to foster this type of innovation. And providing leadership training for future pharmacists to build the new healthcare landscape is going to be critical to the success of the pharmacist being an important member of the healthcare team. So with that, that concludes my presentation. I would really like to open up the line to take questions, and I would like to hear what others are doing at their organization, the challenges that they're facing. So I think it would be great if we could utilize the remaining time to have that dialogue and also to clarify and answer any questions that the audience might have. Lori, I'll take it back to you.
Thank you, Dr. Choe. That was extremely motivating, encouraging, and informative webinar presentation. And at this time, I ask the operator, first of all, if you would just open up the evaluation for those to complete this short evaluation of today's webinar, and then continue on to open up our lines for questions and answers, please.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And we're standing by for questions.
Dr. Choe, I do have one question that came in on the chat that I'll have you address. We had one participant ask, how many patients and providers are at each of the practice sites that you are speaking of?
That's actually a common question that I get for many organizations that are trying to create a practice model like this. And I think it really depends. There's multiple factors that goes into determining panel size or number of FTEs dedicated to some of these health centers. But things that I look at, I don't really have a magic formula that you plug in to estimate the number of efforts needed for a particular panel size. But really, you're looking at how engaged is the practice in terms of team-based care, the willingness of the physician to really delegate some of these care coordinations and the work that pharmacists do to the pharmacist. So most of our practices have, our smaller sites where I have pharmacists half day a week, have at least 2 full-time physicians practicing in an internal medicine or family medicine. And then it varies. And then the site that I have pharmacists 3 days a week, I have 8.5 FTE of clinical FTE for the physicians that's practicing in that health center. So rather than really looking at the number of patients that health center have or the FTE, I really look at all the different elements that I just mentioned to determine how much effort to dedicate to the health centers. And I like to start small because no matter how interested, how invested the practice site might be, the logistical aspect of integrating a new care provider is different. And it takes time. So the last thing I want to do is put a valuable pharmacist resources in the clinic and just not being very productive. So we always start low, typically half a day to 1 day a week, and we build from there as the practices evolve, as physicians become more familiar with pharmacist role, as the pharmacists themselves become more comfortable being embedded in that setting, then we start to gradually increase their effort.
We have a question online from Julie from Iowa. Please go ahead.
Hi, I actually have a couple of questions. One of them is on when your pharmacist sees a patient in the clinic and they come back to these visits or even their initial visit, do you bill that to the insurance company? Is that a fee-for-service payment that you receive, or do you just consider that part of your global fee that you're billing for seeing physicians? And then my second question is, do you also employ health coaches in any of your clinics, or is it only pharmacists?
I'll address the first question. We are participating in the National Demonstration Project Multi-Payer Initiative. So we have 3 commercial payers that pay fee-for-service, and then we have Medicare and Medicaid that gives us capitated payment. So that initial capitated payment that we got actually covers some of the cost of the pharmacist because we're part of the care team that they're paying us for. And then we also bill directly for our services to the private payers, and they reimburse us for those visits, both telephonically as well as face-to-face visits. And then the second question was about health coaches. We don't have health coaches in our health system. I know there are other organizations that have included health coaches into and I've heard great things about them. We just haven't really latched on to that role quite yet, but I am very interested in understanding and learning more about their role.
Thank you.
Once again, for any questions online, that's star, then 1. We have a follow-up question from Julie from Iowa. Please go ahead.
Sorry, you're going to get tired of me. When you bill then to those commercial companies for that physician or for that pharmacist, do you bill those as incident to them to a physician visit, or are they credentialed as their own care provider and paid as such?
So it's a form of an incident to billing, so to speak, because we do bill under the referring provider, but we don't follow the bylaws of the incident to billing. So I guess you could look at it as a form of incident because we don't bill as under Hae Mi Choe as a pharmacist. We bill under the provider.
Okay.
Okay, we have another question in chat. What CPT codes are being billed, and are they billed by the pharmacist, the clinic, or the physician?
So these CPT codes, we actually call we call them G codes, and that's specific to our demonstration project that we're working on. And so that's the code that we bill under for the 3 of our major payers in state of Michigan.
So how would we do it, not being part of a demonstration project? Which really isn't.
So there's a lot of other billing opportunities that's not part of the demonstration. So I'm actually working with physician organizations that are not part of the demonstration project. And it's a little bit more challenging, right? Because then they're They have Medicare Incident 2 billing route that they could use. Just this year, Medicare has released care management codes that pharmacists could also utilize. There are transitions of care codes that pharmacists also could be part of, but remember that transition of care code is not paying for that pharmacist's time, but pharmacists could be that first call that you make within 48 hours, and for the provider to bill a higher reimbursement than just a regular clinic visit. So there's other type of billing that can be done if you have practices that are not part of the demonstration project, but keep in mind that each state has their own practice scope law that could be more restrictive or not. Each state has their own law about what pharmacists can and cannot do. So there's a lot of variability that goes into play. That could be a whole another discussion about billing for pharmacists. But we've been very fortunate in the state of Michigan to be part of the demonstration project that allowed us to bill this way. And even for those of us who are not part of the participating demonstration project, 2 of our large commercial plans have recognized pharmacists providing this type of care, and they're reimbursing us for those services in a different format. That's not a traditional CPT code.
Okay, we have another question from the chat, Dr. Choe, and they want to know what is the average patient load at each center? And while I'm at it, Jennifer, could you please pull up the evaluation so that our participants can complete an evaluation at this time as well while we're still in chat and taking questions?
So I have a minimum expectation for the pharmacist in a half-day clinic. So we expect our half-day clinic our minimum goal is to 5 to 6 patients in a half-day clinic. And our half-day clinic is not 4 hours, it's 3.2 hours because I put in 80-20 rule for administrative versus direct patient contact. So given 4 hours, 3.2 hours is actual delivering the care to the patient, and 0.8 hours is dedicated to documentation and any care coordination they have to do outside of that direct services. So it depends on if your clinic you're just only there half day a week, then your impact that your encounters would be 5 to 6 in that half day. But then if you're there 6 sessions, and you multiply that by 6. And in terms of unique number of patients that we touch, it could vary because some practices, they have a lot more elderly patients. We're doing much more frequent follow-up over the phone, which then increases the number of encounters, but not necessarily number of unique patients. I have some sites where they're really actively working on blood pressure, so all the patients with elevated blood pressure will come back and do a follow-up with the patients if their blood pressure is elevated. So in those clinics, I have high unique number of patients, but the number of average follow-up per patient will be much lower. So while we've created a system and a processes to support that system, we give a lot of flexibility within each practices to really focus and channel their energy in utilizing the pharmacist as the needs arise. And what that does is really empowers each clinic to really own that process while we're maintaining so that we have some consistency across 15 health centers.
Okay, I again have a couple questions that come from the chat. One is, are you measuring patient satisfaction in the demonstration project? And the second question is, how can we stay up to date with the development of this program? One of our participants is working in a community health center doing the same functions, but is experiencing difficulty in expanding this program.
So in terms of, I'm sorry, Gloria, can you repeat that first question again?
Again, the first question was, are you measuring patient satisfaction in the demonstration project?
Okay, gotcha. So we, not for the demonstration project, but we are measuring for our comprehensive med review for our retirees. And so we're measuring that, and we're sending out surveys to the patients, and the feedback we've received from the patients has been just amazing. Not only, in terms of numerical numbers, and our ratings are very high. Again, out of 5, our average is anywhere from 4.7 to 4.8. But what's really impressive and what makes me smile is when I read the comments that patients have stated. And usually when you ask for survey, right, patients are quick about filling out the bubbles, but people don't really take the time to write things in the comment section unless they're really happy or they're really unhappy. And so then we did a data dump of all the comments that people have written, thinking that some will be bad, some will be happy, and every single one of them has been extremely positive. And these comments is what drives me to continue to advocate for pharmacy services and continue to do that on behalf of the patients. So we collect the satisfaction for that subset of patients, but we don't do that for across our 15 centers for our demonstration project. And in terms of keeping up, actually in the struggles that you might be facing, it is not uncommon to run into barriers when you're implementing a program like this. We've launched this back in 2009 with the onset of patient-centered medical home certification within our health system. And I'm very grateful to our leadership within University of Michigan Health System that allowed me to really build this infrastructure and had the vision to create this with me. And sometimes it's not always easy to find visionary leaders who's willing to invest in building this type of model because you don't see the parent dollar per dollar transaction when you're hiring a pharmacist and having them do this type of work. But I do believe, as we're heading towards a whole different payment reimbursement model, I think it's really important for us to look at how we impact quality and the value pharmacists add in that arena rather than just looking at do they bring in the dollar that they spent on paying for pharmacist time. So I think those are going to be important. So at State of Michigan, as we've kind of expanded the UMH model to our ACO network, so now our ACO are working through building in their model. Our Blue Cross Blue Shield is our largest payer in State of Michigan. They got behind us and have supported a collaborative quality initiative where we're going to be focusing on embedding pharmacists in the practices across the state, and we're launching the coordinating center. As we speak tomorrow, I'll be presenting at our quarterly meeting addressing with all the physician organizations in the state of Michigan. The vast majority of them will be there, and I'll be launching our coordinating center to move this model across our state, and that's the vision, is to really create this model across different physician organizations within the state of Michigan and finding solutions to those smaller practices where we can't afford to put a pharmacist there, not even at a half day, but figuring out then how do we then service those physicians so that they have that access to patient care.
Thank you so much. Operator, are there any questions in the queue?
Again, for any questions, that's star, then 1. And at this time, I see we have no questions in queue.
Okay, we have one in the chat box. So how do pharmacists work with the entire care team is the first question. And then does the physician consult the pharmacist, or do you use a risk assessment to identify patients?
Okay, so the first question, I'm just jotting it down so that I don't lose sight of the question. So how we interface with our other disciplines. I think one of the important things that we stress with our pharmacists is to really become integrated with and interact with other healthcare providers, because the last thing we want to do is to complicate the picture even more by trying to compete for patients or trying to overlap our services. So we have, like at some of our clinics, we have weekly huddles with all of our caregivers. So, we have physicians, pharmacists, nurse, medical assistants. So one representative from each discipline. We come together once a week as part of our quality huddle. So think about how would we address some of the metrics that we're not reaching our goal? Who could do what and when? And having the whole team there to have that open dialogue has been extremely helpful, helping us understand what each of our strengths are and leveraging our strengths rather than trying to compete for patients has really helped us to develop and foster that teamwork. And we refer patients to each other all the time. I might be seeing a patient who's had needs for social worker, and I might be sending a message to the social worker and say, hey, can you see, Mrs. Jones, she's really struggling with some of the issues, whatever that might be, that social worker might help. We refer patients to dietitians who really have, inspired to learn more about how to do carb counting and is looking for more in-depth education in that arena, and then we would send patients to the dietitian who could really take that ball and run with that. And we do this, across all disciplines, so that we're really working as a team rather than, in our own silos. And that has really, fostered that home, kind of the teamwork within the patient-centered medical home. In terms of how do we identify patients, we take patients based on referrals, obviously. So, as the physicians identify patients that they think the pharmacist would be helpful, we get those patients. But we also rely on the registry to identify patients not meeting treatment goal. So, for example, I could pull down, go to look for clinic A, and I could say, okay, pull me a list of all the patients whose A1C is greater than 9. And with a click of a button, I could pull that list. And then either the pharmacist or we work with panel managers and say, okay, out of this list, 50 of these patients are probably the best fit to see a pharmacist, and then they might be calling the patient, introducing our services, and getting them, making an appointment with pharmacists in the clinic. So we do a lot of proactive outreach looking at disease-specific registry. We have not developed any risk stratification tools specific to pharmacists. That's something that we have in our queue to work on in the future development to figure out who would best benefit from having pharmacists do a comprehensive med review on. So that's something that we are looking forward to building within our system. But as of right now, we rely on our disease registry to help us with that.
Operator, are there any questions in the queue?
At this time, I see we have no further questions.
Oh, okay, Dr. Choe, we do have a couple of questions for you. Are you using the chronic care management option for your Medicare patients that you've started since January? That's the first question. And the second question is, how do you initially sell the concept to your physicians? Are they resistant?
Okay. So the first question about care management code, we actually, within our system, we do not use this care management code because we're participating in the National Demonstration Project. So since CMS already pays us for care management, that would be double dipping, so we're not allowed to build that code. However, some of the other physician organizations that I am working with have tried to utilize this care management code, and they've ran into some struggles in doing that. And some of that, is a logistical issues, right? Only one person that patient signs off on could be billing this code. There's copay, that's a co-insurance that's affiliated with his monthly charges that goes to the patient, and sometimes patients don't want to pay for that, especially for, when the patients are living under a fixed income. So there's some challenges that came with utilizing this code that has not been widely adopted, but I still think that's still an opportunity where we could kind of capture some of the revenue that exists today. The second question was, how do you promote this to physicians who are resistant to pharmacists' role in this? And this topic could be another hour topic of discussion because, there's different reasons why physicians are resistant, and it's hard to generalize one strategy to fit that barrier. I mean, in a nutshell, I think since we only have like 3 minutes left, it's hard for me to go deeper into this discussion. But I think, understanding physician's pain point is really important when we go to the physicians and helping the physician. And that pain point is different for each physician. When you, for example, going to a new practice where physicians themselves are new in terms of, building their practices, the last thing you want to tell them is pharmacists could help you improve your access, right? Because that's not the pain point. In fact, that's perceived as negative because now they're taking patients away from the patients they should be seeing, and vice versa. So there's other things, and so, again, in 2 minutes to go, it's hard for me to go into each detail. But collaborative practice agreement could be another example. Some physician might say, well, this is great, so you mean that I can delegate this regarding you don't have to come and ask me every time you make med changes? But then on the flip side, some physician might say, what do you mean you're going to be changing meds on my behalf? That's my job. So you have a full gamut of even physician perception of the same collaborative practice agreement. So understanding physician's perspective of what's important to them and what's helpful to them, and begin to chip away at that is the best approach in developing that relationship with the physician, and not go with like one approach for all physicians, because it's going to be different depending on who you talk to. That's a great question, and it's a question that I think warrants probably a longer discussion.
Well, Dr. Choe, we are at the top of the hour. That was an amazing presentation, even more so the answers to the questions that come out of our audience. So at this time, I just want to thank you for an awesome presentation, and thank you to our audience for joining us today on the webinar for Pharmacists Transforming Care in Patient Medical Home Model and Accountable Care Organizations. I will remind you the slides will be available on our Lake Superior Quinn YouTube page within the next week, and at this time, we're going to end our webinar, and thank you all again, and have a great day.
Thank you.
Thank you.